Welcome, dear students, to R.A.T.S in Pathology. That is, Racing Against Time for Students in Pathology. And the topic that I'm going to take is of paramount importance, namely the nephrotic syndrome, part 1. This has been asked as an essay, a short essay, submitted as a clinical case, a multiple choice question form, Viva OC, etc. in pathology, medicine, as well as in pediatrics. And I hope that this class will serve the purpose. Defining the term. What is the definition? Nephrotic syndrome is a manifestation of glomerular diseases which presents as massive proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia. Massive proteinuria means there is more than 3.5 grams of protein per deciliter that is excreted. And along with it, there will be hypoalbuminemia, generalized edema, and hyperlipidemia. This is a recap of the glomerulus. I find that there is an arteriole that is entering, there is a tuft of capillaries, and a venule that is leaving. This is the Bowman space. Let us concentrate on the capillaries alone. I find that there is an epithelium externally and an endothelium internally. This is a Bowman space. And after the excretion, you find that there is the tubule that can do the reabsorption. Please have this diagram in mind. Coming back to the definition, you find that there is excess glomerular permeability to plasma proteins. Initially, you find that only low molecular weight proteins are excreted, and this is called as selective proteinuria. After some time, you find that it can become non-selective. Even large and small molecular weights can be excreted together. Also, there is a reversal of the albumin globulin ratio because of the loss of albumin. And finally, owing to the loss of protein, there can be a loss of the colloid osmotic pressure, which can result in a generalized edema. So these are the features which you people shall and will understand and reproduce. This is a picture of the Starlings hypothesis, a topic of importance in general pathology, the edema. Edema itself can be because of increase in the hydrostatic pressure or a decrease in the colloid oncotic pressure or both. And that is called Starlings hypothesis. And that is what is happening. And this is a blood vessel. You find that there will be a hydrostatic pressure. When it is increased, there can be an edema. Similarly, when there is a loss of proteins, there can be an increase in the colloid oncotic pressure, and that can again lead to an edema. So please remember these things. In addition to this, there can be an edema due to the retention of sodium and water, that is because of aldosterone. What is hyperlipidemia? You find that there is an increase in the production of low density lipoproteins as well as very low density lipoproteins and a decrease in HDL. Because of the increase in the lipoproteins, you find that there can be an excretion which is called as lipiduria. And this increased amount of synthesis can occur in the liver. Owing to the excretion, there can be fat globules which can be present in the tubules. They reabsorb, and I find empty vacuoles in the tubules. So that is hyperlipidemia. And they say that nephrotic syndrome can be associated with atherosclerosis as well as coronary heart disease. What are the other manifestations of the nephrotic syndrome? There is an increased amount of permeability. Not only the proteins are lost, but even the immunoglobulins. And when there is a loss of immunoglobulins, it leads to infection. Again, there can be loss of anticoagulant factors such as antithrombin 3. So when there is a loss of anticoagulant factors, it leads to clotting, resulting in thrombosis, such as renal vein thrombosis. Nephrotic syndrome, as a summary, we shall have these in mind: massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, infections because of the loss of complements, and thrombosis. This is a beautiful flow diagram. I would like you people to kindly follow it. You find that there is an abnormality in the glomerular capillary wall. This leads to increased amount of permeability and proteinuria. There is a loss of serum albumin resulting in hypoalbuminemia, which reduces the oncotic pressure, which leads to an edema because of the plasma volume increase. Also, you find that there is an accumulation of fluid in the interstitium, leading to generalized edema or anasarca. As far as the liver is concerned, you find that there can be increased amount of lipoprotein and there is a leakage which leads to lipiduria. And there is a decrease in the albumin, which is not compensated. Nephrotic syndrome itself, when the question is asked, we are supposed to write the causes. And they are divided mainly into the primary causes and the secondary causes. Primary causes we shall remember, and each one of these can be asked as a question. Minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, membranoproliferative glomerulonephritis, IgA nephropathy, and hereditary. So the first five can be asked as questions. And there are also the secondary causes, which can be any systematic disease, such as diabetes, infection, eclampsia, and it can be because of certain drugs and toxins. So this is a beautiful picture showing the general stature of the nephrotic syndrome. Bilateral pedal edema, there is an ascites and there is a bloated face because of edema called as anasarca. And it is a wonderful mnemonic. I would like you people to kindly by heart it. It is not nephrotic, it is nephrotic, the edema. So Na, and there is a decrease. Because of this, there is hyponatremia. Albumin is also decreased, hypoalbuminemia. Proteins are excreted, proteinuria. Lipids are increased, hyperlipidemia. Thrombosis of the blood vessels, renal vein thrombosis. Edema generalized, orbital edema, periorbital. And thromboembolism because of thrombosis. In addition to it, there will be infection and coagulability. So please remember this mnemonic: nephrotic, Nephrotic. It is a very great mnemonic and this is a reference for it. Due credit to them. Nephritic syndrome is another condition, and usually when this is asked, the students misanswer it and write the nephrotic syndrome. For the nephritic, I have already covered it, but let us recollect the mnemonic pharaoh: proteinuria and edema, hematuria, azotemia, RBC cast, antistreptolysin O titers, oliguria, and hypertension. So this is nephritic, previous is nephrotic. Please remember both of great importance. We shall continue with the minimal change disease, otherwise called as lipoid nephrosis. The minimal change disease, MCD, sometimes that is abbreviated form. The synonyms are, it can be called as lipoid nephrosis or foot process disease. And by definition, nephrotic syndrome, it is associated with the diffuse loss of the foot processes. What it is, we shall be seeing. More common in children, particularly in the age of 2 to 6 years. And the predominant etiology is idiopathic. That is, we do not know the cause of the disease. But it can be associated with respiratory infections, with immunizations, etc. Because of this, an immunological etiology has also been suspected. Why? Because it follows the infections, it is associated with immunizations, it responds to steroids. And there can be other immunological diseases such as eczema. And it is also associated with HLA-B8 and HLA-DR7. Since all these factors are immunological, it is also thought to be an immunological disease. Look at this picture. If I get the letters over here, this is a normal glomerulus. I am finding the epithelium and this is the endothelium. And normally I find these are the foot processes, as though it is standing on multiple legs. And this is the capillary. What happens in a case of minimal change diseases? There is a total bald epithelial cell. There is no foot process that is seen. And they say that this is because of the edema. Because of the edema that is occurring over here, all the foot processes get fused together and hence it appears also they are lost. So it is a minimal change disease, the morphology. Have this in mind. And what are the clinical features of it? It generally follows an upper respiratory infection, can be associated with Hodgkin's lymphoma. And it is also associated with focal segmental glomerulosclerosis, FSGS. And it follows prophylactic immunization, any vaccine. So these are the clinical features. And this is a cartonic form of it. You find that there can be an edema, there is a massive proteinuria, etc. Hyperlipidemia because of the increased amount of lipids which are produced. This particular diagram I would like you people to draw. It is easier and it can be drawn very lucidly. This is a normal glomerulus and this is the epithelial cell showing the foot processes. Whereas in a case of minimal change disease or in a lipoid nephrosis, there is a blunting of it or the fusion of the foot processes which are not seen. And this is the endothelium. And this gray area is the basement membrane. This cell here is the mesangial cell. So concentrate only on the loss of the foot processes. Now what is the picture? In light microscopy, always in a case of glomerular pathology, we should have the light microscopy, the electron microscopy, and the immunofluorescence. Three pictures must be mentioned. The glomeruli appear almost normal in light microscopy, so nothing much for us to bother. There is no thickening of the basement membrane, no cellular proliferation, and you find by electron microscopy, the visceral epithelial cells, that is the external cells, will be showing loss of the foot processes or the fusion of the foot processes. They are swollen and flattened. And the tubules will be showing reabsorption of the lipids and hence there can be vacuolation. So this is a pathological picture. I repeat once again, glomeruli are normal. There is no thickening of the basement membrane, no cellular proliferation, and in electron microscopy, there will be loss of the foot processes. The tubules will be showing reabsorption of the lipids. Look at this electron microscopic picture. This is the capillary lumen. This is the endothelium. And this is the epithelium externally. And this gray one is the basement membrane. So here I am seeing multiple foot processes of the epithelial cell. Whereas this is a case of this one. So there is an epithelium, and I am not finding any of the food processes in it. And this is the basement membrane, and this is the endothelium over here. So the fusion of the food processes shows flattening. So electron microscopy I had mentioned earlier. So there is a loss of the food processes due to fusion of them, and there is a flattening. Immunofluorescence, nothing remarkable because there are no complexes. And what is the clinical course of the disease? Generally, it has a good prognosis in spite of a massive proteinuria. Spontaneous remission, that is, it gets all right even without treatment. And it responds excellently to steroids. In case it does not respond, it is resistant, it can progress onto focal segmental glomerulosclerosis. So remember these points. Lipoid nephrosis itself has been asked as a short note, or it can be part of the essay. And this is a summary form. You find that common in children, loss of the food processes, lipid droplets can be seen in the tubules. The origin is unknown or idiopathic. Some people say it is immunological, and the prognosis in general is good. And these are the diagrams, kindly have them in mind. And the last topic for today will be IgA nephropathy. It is a short one, just pay your attention. IgA nephropathy, it is otherwise called as Burgess disease, and it is a glomerular disease which manifests as a deposition of IgA, immunoglobulin A, in the mesangium. So IgA in the mesangium. It is also the IgA, you find that it is implicated in certain other diseases such as autoimmune vasculitis or hinox purpura. Some people call it as IgA vasculitis. This is a beautiful diagram. I would like you people to kindly draw and remember this. What is the pathogenesis of IgA nephropathy? There is a galactose deficient immunoglobulin A which is present in the serum, and this gets deposited in the basement membrane or in the mesangium. Also, there is a production of IgG antibody. So this acts as an antigen and there is an antibody against it. So there is an IgA, IgG complex which is formed, which gets deposited in the mesangium. So there is a mesangial deposit. Whenever there is a deposit, there will be an inflammatory or an immunological reaction which can lead to an injury. Because of this, you find that there can be a damage to the basement membrane, etc., which leads to the leakage of proteins and the RBCs. Once again, I say, because this again will be the key diagram for this, there is a galactose deficient IgA. IgG antibody is formed. IgA, IgG together form a complex which is deposited in the mesangium. This leads to mesangial injury as well as basement membrane injury, because of which there can be leakage of the proteins as well as RBCs, which means patient will be having proteinuria as well as hematuria. The light microscopic picture, this area is probably the mesangium, and I find that there is a homogeneous eosinophilic deposit over here, and this is a PAS positive deposit which is found. These are all the capillaries that are there which are not very much affected in it. IgA nephropathy or nephritis, confined to the mesangium initially. And look at this also. These are all capillaries which are not affected, but the connecting link, that is a mesangium, that is getting affected, and I find immune complexes which are being deposited in the mesangium. These fluorescent areas are all the immunological deposits. The mesangial deposits are there showing the immune complexes. They can be diagnosed by immunofluorescence. It can cause glomerulonephritis, and sometimes there can be what is called as crescentic glomerulonephritis. What is a crescentic glomerulonephritis? We shall see later. And what can be the clinical manifestations? Hematuria, hypertension, crescentic glomerulonephritis. Blood vessels can undergo sclerosis. And sometimes there can be a renal failure. Though it is a slowly progressive disease, ultimately it can lead to a renal failure. As mentioned earlier, the IgA, this itself is an antibody, but whether this is acting as an antigen and IgG is an antibody remains to be known. Blagazario,